Sorry for the shameless UF, University of Florida pictures here. So I'm Shawn Taylor. I did all my training down in Florida, advanced imaging at the University of Florida, and came back. I'm native Idahoan. I was born and raised in Payette, Idaho, if anybody knows where that is, down south outside of Boise. So anyway, today we're going to talk about cardiac arrhythmias that are associated with heart failure. And there's a lot to talk about. Full disclosure, I'm not an electrophysiologist who have more expertise than I do, but I think we can get some good discussion and share some knowledge here. So if we can go to the next slide, please. All right, so first off, what arrhythmias are associated with heart failure? Why do they matter? Well, to be honest, you can get really any cardiac arrhythmia can be associated with heart failure. By far and large, we have atrial fibrillation leads the way, followed by ventricular tachycardia. They're the most prevalent and kind of bread and butter cardiology that we deal with. They are major drivers in mortality and hospitalizations in people with heart failure, really adding to the cost of healthcare in this country and around the world. As we've seen in many of the discussions before during this series, the costs are kind of astronomical. Arrhythmias can either come secondary to heart failure, or they can be the primary cause of heart failure, and we'll kind of discuss a little bit about those today. Next slide, please. All right, so first, a little bit of pathophysiology. What happens to the heart? Well, in heart failure, we get structural remodeling and fibrosis, where the myocardium or the heart muscle is replaced by scar tissue. And that can be a pro-arrhythmic process, leading to abnormalities in the electrical conduction within the myocardium itself. Other processes can include calcium dysregulation, neurohormonal, and autonomic activation. And these are just very superficial kind of what's going on and kind of a description of the processes we're going to talk about. Next slide. Okay, so first off, everybody is probably quite familiar with atrial arrhythmias, especially atrial fibrillation. And like I said, this is the top arrhythmia that we see related with heart failure. So atrial fibrillation is often seen in non-ischemic cardiomyopathy because if atrial fibrillation occurs and it goes faster than, let's say, 110 beats a minute for a prolonged period of time, days, weeks even, because you have some patients who will come in and they say, I'm really short of breath, I have palpitations, but some people don't feel it. Especially I've noticed in diabetic patients, they may not know that their heart is beating at 120, 130 beats a minute, and they could be sitting there for weeks on end and then end up showing up to the clinic or the hospital with fluid overload, shortness of breath, lower extremity edema, and not know why. And then their EF you get an echo and it's 25%. And not having had an ischemic event, it's just because the heart was racing so much that it eventually decided to cry uncle and give up a little bit. So there is this bidirectional relationship with heart failure, whereas AFib can cause systolic heart failure, but also systolic heart failure can cause AFib. And that happens because when you have left ventricular dysfunction, you usually get an increase in pressure that can either cause mitral regurgitation and eventually cause increased left atrial pressure. And it's the stretching of the left atrium that can lead to atrial fibrillation, especially around where those pulmonary veins enter the left atrium is usually where we see the nidus for AFib. It's up to 50% prevalence in heart failure patients. And obviously, we know it increases the stroke risk because of thrombus that can form in the left atrial appendage, which is why we give anticoagulation for most AFib patients. Next slide, please. All right. Sorry for the blurriness of this EKG. It didn't look as blurry when I sent it over. But anyway, I think we can still see that this is just a typical AFib EKG. We have irregular R to R intervals. You'll just have to trust me that there's no discernible P wave on this EKG. And like we talked about, uncontrolled rates persisting over 110 beats a minute increase your risk of heart failure. So yeah, this is just a normal AFib EKG. Next slide, please. So what do we do about it? That's the big question, right? So rate versus rhythm control. Has been discussed and studied a lot in the cardiology world. So I think in my training and in my opinion, everybody deserves a trial at rhythm control. And usually we'll start that out with a cardioversion if they have persistent atrial fibrillation, and then add antiarrhythmics on top of that, or rate control with beta blockers. A lot of that will also depend on left atrial size and things like that. The larger the left atrium is, the less chance that a cardioversion is going to be successful and someone will remain in normal sinus rhythm. But if they have a fairly normal sized atrium, usually cardioversions do pretty good, at least in the short term, until you can start them on a good medical therapy for that. Excuse me. Rhythm control in heart failure patients, if you have reduced EF, rhythm control is favored over rate control with just a beta blocker and everything. We really try hard to get these patients back in normal sinus rhythm, and there's clear benefit of that over just rate control with heart failure patients. Next slide, please. All right, so there was this trial, Castle AF, in 2018. It took about 363 patients and qualifying EF 35% or less, and it randomized them in ablation arm versus just medical therapy, and it followed them for about 3 years. And they found significant reduced endpoints in the ablation arm over the medical therapy arm. So all-cause mortality, 13.4% in the ablation arm versus a 25% in the medical therapy arm, which is pretty significant. And then if you look at hospitalizations, 20.7% in the ablation arm versus 35.9% in the medical therapy arm. Again, quite significant, especially when we're talking about extrapolating that across the whole healthcare system and cost and lifestyle for these patients. So a reduction in atrial fibrillation below 50% burden at 6 months was a real strong positive indicator, and they moved ablation for AFib up to a class 1 indication at that time. It is important to note, though, all of these patients had a device, and that was helpful because, well, how do you know someone's below 50% burden, which often comes up because, you can't just continually wear a Zio patch or, an external monitor. The development of the Apple Watch has actually been quite helpful. I don't know if Chris or other people on here have noticed that, but it's been really helpful for me and my patients, where to say, okay, you wear a watch or some monitor that's wearable. They've gotten pretty good at detecting AFib, actually. So this was later expanded onto another trial in 2023 for end-stage heart failure, but we're not going to get to that one. Okay, next slide, please. All right. Other atrial arrhythmias, atrial flutter, ablation is first line, especially in typical flutter. This has a really high cure rate. Just had a patient today, actually, got an ablation yesterday. He came in with an EF of 20%, doing quite poorly. But, in these arrhythmias that cause systolic heart failure, I think the vast majority of the time we do get significant amount of that function back. Aside from, when they have ischemic events, that's a little bit harder. But with these non-ischemic cardiomyopathies that are arrhythmia driven, oftentimes we can get normalization of the EF. Heart failure patients can develop atrial tachycardias, and these arrhythmias also, just like atrial fibrillation, you lose what's called the atrial kick, which is the squeeze of the left atrium to fill the left ventricle better. And so that can, with someone who already has a compromised ejection fraction and squeeze of the left ventricle, losing that extra squeeze from the left atrium can further compromise their cardiac output. Okay, next slide. All right, this is just an A flutter EKG. You have your sawtooth appearance. The difference is, just a quick point out between this one and an AFib EKG, is these R-to-R intervals are, I would say, usually regular. You can have, variable blocks in atrial flutter as well, but this is a typical flutter with normal R-to-R intervals. And cardioversions and, the treatment's quite a bit the same as AFib. Okay, next slide. Okay, so that's the atrial arrhythmias kind of in a nutshell. If we move on and we talk about ventricular arrhythmias, these are a little bit, I guess you could say, scarier arrhythmias, and more seen in ischemic cardiomyopathies. I have to apologize for the formatting there. It looks like some of the things got cut off when it's sent over, but this is kind of the idea when someone has an ischemic event. You have this, I don't know, can you see my cursor moving at all? Probably not. Okay, that's okay.
No, and I think this is a Mac PC issue, but thanks for working with it,
Yeah,
Shawn.
sorry. So on the left, you can see this dense scar, and that happened most likely because of an ischemic event, and it creates this isthmus, is what we call it, of a kind of a continual circuit in the ventricle where electrical activity can just go round and round this area and exit through the scar. And this is how it causes ventricular tachycardia, ventricular VT storm. And this is a significant cause of sudden cardiac death in patients with ischemic cardiomyopathy. Other ventricular arrhythmias are high PVC burdens, and you can see that as well with heart failure. Next slide, please. I think I comment a little bit more on the next slide. So this is ventricular tachycardia, fast QRS complexes, regular R-to-R intervals mostly. There are some other nuances like AV dissociation and stuff that we won't dive into, but this is a typical VT EKG. All right, next slide. So evaluation of scarring in the cardiac is a cardiac MRI kind of gold standard situation. And this is, I tried not to put too many slides on this, but I got a little excited because this is kind of what I do. So it's gold standard for evaluation of myocardial scarring. And scarring evaluation is actually really important in people with ischemic cardiomyopathy, non-ischemic cardiomyopathy, really all cardiomyopathies. To evaluate whether or not you have, I guess you could say, scarring or infiltrative disease, such as amyloidosis or sarcoidosis, things like that. But it can guide diagnosis, and it can help whether or not you're going to put in a prophylactic ICD and whatnot. So next slide, please. All right, a little bit of show and tell here. There's some of my cases that I had saved. So this picture on the left is a short axis view of the left ventricle. The arrow signs really help. So the myocardium, it should all be black. And this is what we call a delayed gadolinium enhancement image, where in the MRI, we use kind of a contrast called gadolinium, and it will usually go into the myocardium and get washed out very quickly. So when these pictures are taken, it's all black. But gadolinium will get held up within the myocardium when the cellular structure is not normal, whether there's scarring, whether there's infiltration with amyloid or sarcoidosis, whether there's an inflammation. It'll get held up, and then we take these images, and the myocardium becomes bright, like you can see that the arrows are pointing to on the left. And this is typical for ischemia because it's the subendocardial layer and almost all the way thick, the full thickness of the myocardium, especially towards the top there. And then you compare that to the right picture, and that white kind of horseshoe looking area at the tip is the apex, the tip of the heart. And that is also very consistent, probably with a big LAD infarction. Next slide, please. All right, so that picture on the right with the apex, I just wanted to put this in because it correlates very well. This same patient, if you look at the top of the picture, you see this is the left ventricle. And when we have scarring, scar doesn't move. So you can have a clot formation, a thrombus form at the apex. And this is what is demonstrating there. So just a complication of reduced EF and ischemic cardiomyopathy, usually because you get an akinesis of the wall, usually found in the apex with thrombus formation. Okay, next slide. And this is just another complication that I had to put in there because it was so impressive. This person had ischemic cardiomyopathy and a rupture of the septum towards the apex of the heart. The picture on the right is just showing flow across the septum from the left ventricle to the right ventricle. I just thought that was neat, so I threw it in there. All right, next slide. All right. So talking about antiarrhythmics for all of these arrhythmias. So we have 4 classes of antiarrhythmics: sodium channel blockers, your quinidine, procainamide, and then lidocaine, mexiletine, 1B, and 1C, flecainide, and propafenone. And these are a no-go in heart failure with reduced ejection fraction or structural heart disease. Class 2, everybody's real familiar with your beta blockers, your metoprolol and Coreg and all those things. Very commonly used, safe. Class 3 are your potassium channel blockers, and that's your amiodarone, your sotalol, your tafidilide or Ticasin, the other name for it. In class 4, you have calcium channel blockers, and we try to avoid these in heart failure with reduced ejection fraction because they will have a negative ionotrope effect and can worsen heart failure, except for amlodipine, that usually is just fine. Okay, next slide. Antiarrhythmics in heart failure, amiodarone is an old kind of go-to medication, very effective for both atrial and ventricular arrhythmias. Like I pointed out, it's a class 3 antiarrhythmic affecting these channels, sodium, potassium, and calcium channels. The problem with amiodarone is that it does can have significant adverse effects, such as pulmonary, thyroid, ocular, and liver issues. And so those are monitored, with an eye exam every year, PFTs, labs. And usually if you keep the dose 200 milligrams a day or less, you don't really see that. But we do, everybody plays it a little different, but I tend to reserve this medication for elderly patients, usually above the age of 70, 75. Just to avoid those long-term effects, because it is a kind of an additive thing. Avoid class 1C agents such as flecainide and propafenone in heart failure with reduced ejection fraction, secondary to the CAST trial. So this is a good trial that showed 2 to 3 times increased mortality in post-myocardial infarction patients due to its pro-arrhythmic risk. So that's something very important to keep in mind. Next slide. Okay, so role of catheter ablation in ventricular tachycardia or high PVC burden is strongly indicated, especially for refractory or recurrent VT. Helps avoid the future ICD discharges, and high PVC burden, like we talked about, usually they say over 10%, but usually pushing around 20% PVCs, you start having that increased risk of systolic heart failure. And PVC ablation is recommended in those patients. All right, next slide. So CRT, we need to talk about. So CRT is indicated in patients with New York Heart Association classes 2 to 4. an ejection fraction of 35% or less, and QRS duration 130 milliseconds or greater. It decreases sudden cardiac death and also can improve the ejection fraction due to resynchronization of the ventricles. There's a nice picture down there at the bottom of it, but next slide, please. So the MADIT CRT trial was done in 2014, had 1,820 patients for ischemia and non-ischemic patients, and they randomized 2-to-1 into the CRT defibrillator arm versus just an ICD without the resynchronization therapy. And the primary outcome of a 34% reduction in death or heart failure events, although you have to note that most of it wasn't in the death column, it was in the heart failure event column, but still significant in the resynchronization arm. So if you have ischemic cardiomyopathy, class 1 or 2, or non-ischemic cardiomyopathy with a class 2 symptoms, and an EF of 30% or less, QRS of 130, then this is strongly indicated, and it improves the cardiac remodeling cycle. Okay, next slide. But devices aren't risk-free, so it's really important that you talk to patients, talk to family members, because usually these patients are fairly elderly, and hopefully they've brought their kids along with them or their grandkids, because we put these devices in, but they're not free of problems. They can become infected. Device-related endocarditis can, initially is very, very low, but if someone has this device for 20 years, then their risk can rise as high as up to 7% over the lifetime of having the device of an infection. You also have discharges that are inappropriate. Those can happen as well, and that can be very almost disabling to the patient, because they can develop kind of like a lot of stress and post-traumatic stress syndrome from discharges, because you're always kind of waiting, is it going to shock me? So it's always in the back of their mind, and that can be affect them quite a bit. Pneumothoraxes, it's an implantation, known complication, kind of rare, but that does happen. So talking with the patient and saying, hey, these are the risks, this is what could happen down the road, is important. Next slide, please. Device monitoring. So, the usual approach is a mixture of home and in-clinic monitoring. There's probably some variability between clinics. Pacemakers and ICDs both have a constant home monitoring device. They have in-clinic downloads, and then they get sent home with a device that will constantly Bluetooth and send information to the company and to the clinic. Usually for us, we do device downloads hard in clinic every 6 to 12 months for pacemakers and every 3 to 6 months for ICDs. And then changes can be made at that time if needed. Some challenges that I've experienced, especially in rural Idaho, is poor or no internet connection. They live up in the mountains and nobody services that area. So that can be difficult. Some of my patients actually will drive to the local McDonald's, connect to the internet, upload their information, drive back, and they'll do that on a kind of a weekly basis. And then compliance is always an issue. You can send these people 3 monitors at home and somehow they all get lost. But, all we can do is keep trying at that point. So next slide, please. So this is a picture of the different kinds. They're pretty simple nowadays. They kind of just sit right next to the bed and communicate wirelessly with the device. And pretty slick, actually. So, all right. I think that, bradyarrhythmias. This is one slide. Bradyarrhythmias, pretty much put in a pacemaker or cut back on medications if it's iatrogenic. I mentioned here AV block with infiltrative cardiomyopathies, but I think that's information for a different talk. So, all right, next slide. So key takeaways: heart failure symptoms and outcomes are worsened by arrhythmias. Multiple treatment options. It's best to get them in early, um, and evaluated that way, so we can stop any remodeling or pressure differences within the left ventricle and atrium that are causing remodeling taken care of. Choosing the right treatment is important, and discussion with the patient and their family. And then antiarrhythmia treatments definitely reduce mortality and morbidity. All right, next slide. I think that's it. All right, thanks everybody.
Very nice, Shawn. Thank you so much for that great overview. A lot to talk about, and people can be putting their questions in the chat, or please raise your hand. I'll go ahead and start things off. So this is a group of primary care providers, right? And so the question I guess I have for you is two things. We'll talk AFib and then sudden cardiac death risk. When should a primary care provider be referring someone to cardiology, maybe within the Kootenai Health System, if you could speak directly to that? And to answer that question, if you could give an example of, from your prior experience, maybe someone you think should have been sent earlier, and then give a good example of someone who could be managed by primary care for both of those scenarios, AFib and sudden cardiac death risk.
Yeah, sure. No, great question and things to discuss. So I always recommend AFib, straight referral, because you need to find out, you need an echo, you need, do they need anticoagulation? Is there something else going on that's causing the AFib? Is there mitral regurgitation? Is there, other things? Do they need ischemic evaluation? So I think newly diagnosed AFib should always be seen by a cardiologist initially. And then ones that definitely should be followed regularly by a cardiologist. Any reduction in EF, severe valvular disease that could be causing it. And then other discussions, maybe they don't want to take a blood thinner, maybe they want a Watchman. Discussions like that can be had at length. But I think primary care's physicians and providers can do a great job in kind of these patients who have paroxysmal atrial fibrillation that comes and goes. They're normally in normal sinus rhythm. They're on a blood thinner, and they're on a little bit of metoprolol or diltiazem or something like that. And they've just been stable, and they don't really have any heart failure symptoms or evidence of heart failure. I think those are very appropriate to be followed by their primary care.
Yeah. So everyone with heart failure and AFib should see cardiologists at least once, and then maybe, depending on the situation, could be referred back.
Correct. Yeah.
Yeah. And then sudden cardiac death risk. The question is maybe, are there patients who are lower risk that might be managed, or can a primary care clinician make an assessment of risk and then based on that refer to cardiology only if the risk is above a certain threshold? And how would you recommend doing that in primary care?
That's a little bit trickier because, in sudden cardiac death, first you have to identify the etiology of the heart failure. If they've had an ischemic event, and if they're having, some PVCs that, they had ventricular bigeminy on an EKG, and then they're having some symptoms, they really should probably be referred over, get a cardiac MRI, see what's going on. Is their EF still normal? But say they only have some PVCs and the MRI is normal, then refer back to the primary, and they can follow there if they're real low risk for sudden cardiac death.
And just to make the point that an ICD, the benefit of an ICD is probably similar between ischemic and non-ischemic in terms of relative risk reduction of sudden cardiac death, but the absolute risk of sudden cardiac death is higher in ischemic cardiomyopathy. So the absolute risk reduction is lower for non-ischemic cardiomyopathy, and particularly for people who are at higher risk of complications, multi-comorbidity, older patients. then the risk benefit is maybe not beneficial. So just want to
Yeah.
add that.
Yeah, I agree.
What questions do people have? Please come off mute, raise your hand. Well, if there are no further questions, we can certainly talk about more of these topics in the case discussion, because I think our case will illustrate a number of these. So shall we move to that, Lindsay?
Sounds great. If there are lingering questions, throw them in the chat and Shawn can get to them there as well. So great, thank you. Um, so thank you so much. We have Patricia is going to be presenting our case. Patricia, could you introduce yourself? Let us know. Oh my God, did we lose her? Oh, okay. Hong Yan is trying to track her down. Rats. Let's give just a sec. Hong Yan will give us an update in a minute.
I can maybe ask another question for Shawn while we wait. So Shawn, you talked about Apple Watch as a way to monitor for burden of atrial fibrillation. Can you talk a little bit about patch monitors and what are all the different options for if we wanted to order a test?
Mhm.
Um, what's the difference between a patch monitor maybe versus an event monitor or a Holter monitor? People may not
Yeah,
know.
right, right. So usually, say someone comes in with palpitations or they've had AFib on an EKG and you're trying to determine what is the burden, how often are they having AFib. Usually I will not reach for a Holter just because that's, 24, maybe 48 hours. I'll do at least a two
Mhm.
week patch monitor, which will really kind of give us a good amount of time to monitor how much AFib, if any, they're having, and other arrhythmias. And then, say someone comes in just palpitations, you don't have any diagnosis. Um, then I get into the questioning. I say, okay, well, how often are you having palpitations? How long are they lasting? Because if I have somebody come in and they say, well, I have palpitations on a daily basis, I'm not going to put them through the rigors of a 2 week monitor with the tape and everything. In that case, 3 days, 5 days, maybe. But if someone comes in and says, well, it happens every now and again, maybe once a week, well, then they're going to get a 2 week monitor.
Yeah. And then I would also add just for people to be aware, there are some monitors that are continuously being monitored, event monitors that if someone has a long run of ventricular tachycardia, that will go and someone will be notified about that. Whereas many of the patch monitors, they're just wearing the patch and then you don't find out until they mail it in. So just be aware that you understand when you're ordering those tests what they will give you.
Right. The struggle with sometimes with those is does insurance cover those ones? They'll pick
Exactly.
and choose what they want to cover. So
Exactly.
yeah.
So like a Zyopatch, Conrad asks, yes, a Zyopatch is one brand.
Hmm.
There's other brands. Exactly. And then we'll ask, Stephen has a question and then we'll go to the case because I think we have Patricia now.
Yeah.
Are there any definite exclusion criteria against cardioversion for new continuous AF, such as LA diameter greater than 4?
I don't think there's any. The only absolute contraindication I know of is if there's a left atrial appendage thrombus. So we
Mhm.
also will do a transesophageal echocardiogram before, especially if they haven't been on anticoagulation very long, um, to check for that. If there's a thrombus, then we don't cardiovert. Obviously, we don't want to cause a stroke. But even if the LA is kind of larger, I usually give them one shot.
Yeah, totally agree. And of course, they have to be able to take anticoagulation.
Mhm.
So if there some contraindication to anticoagulation, also would
That's
be
fair.